let's talk about thyroid biomarkers. Starting with the thyroid stimulating hormone. TSH is a 28 kilodalton glycoprotein secreted from the anterior pituitary gland in a pulsatile fashion. It follows a circadian rhythm. Its action on the TSH receptor on thyroid follicular cells as a part of the hypothalamic pituitary thyroid axis make it primary regulatory drive of thyroid hormone secretion. Measurement of serum TSH is the most common and reliable test for screening of thyroid dysfunction. This is because the negative feedback loop from T4 to T3 onto pituitary TSH secretion follows a log linear relationship, resulting in more significant changes in TSH concentrations relative to small changes in thyroid hormone levels. TSH is currently measured using third and fourth generation ultrasensitive radioimmunoassays with associated degrees of precision to less than 0.002 microinternational unit per milliliter and sensitivity up to 97%. The currently accepted normal range of serum TSH for adults is 0.4 to 4.12 milli-international unit per liter, with minor variation depending on the specific assay used. TSH measurement is indicated as a part of evaluation of suspected thyroid dysfunction, as well as for screening and surveillance in high-risk settings such as pregnancy. Despite its overall high yield as a screening test, TSH values should be interpreted with caution in a number of non-thyroidal health states that can affect its measurement, such as pregnancy, non-thyroidal illnesses like thyroid 6 syndrome, and medications such as glucocorticoids, furosemide, anticoagulants, and metformin. Now, the tetraiodothyronine and triiodothyronine. Serum measurement of T4 and T3 is an important confirmatory component in the evaluation of thyroid dysfunction. The vast majority of both thyroid hormones in systemic circulation are bound to plasma proteins such as T4 binding globulins, with less than 0.2% of hormones available in the free, biologically active states. Because of this, measurement of free T4 and free T3 levels are more accurate in reflecting thyroid function compared to measuring total hormone levels, which can be falsely affected by the presence of various circulating transporter proteins. The measurement of TSH and free T4 are most commonly paired thyroid function tests because of their accurate interpretability in the majority of scenarios, including the diagnosis and treatment monitoring of thyroid function. Free T3 is not as useful for the diagnosis of hypothyroidism, but it can be useful for the confirmation of other conditions such as hyperthyroidism and euthyroid 6 syndrome. All forms of thyroid hormones are measured using modern competitive immunoassays with mild variations in normal ranges depending on the method and manufacturer. Normal reference ranges are also age dependent with different standards for pediatric and adult population. Thyroid antibodies. The measurement of serum thyroid autoantibodies is useful in the diagnosis of various autoimmune thyroid diseases, although their variable sensitivities and specificities require caution in test interpretations. The three most commonly measured autoantibodies are anti-TPO antibodies, anti-thyroglobulin antibodies, and anti-TSH receptor antibodies. The measurement of anti-TPO antibody is the most accurate and commonly used screening test for autoimmune thyroiditis. TPO antibody is positive in over 90% of patients with autoimmune thyroiditis as well as 80% of patients with Graves' disease. However, it also has a false positive rate of 10% to 15%. Measurement of thyroglobulin antibody is commonly performed with 80% sensitivity for autoimmune thyroiditis and 30% sensitivity for Graves' disease, and a similar false positive rate as TPO antibody. Importantly, the presence of thyroglobulin antibody interferes with the interpretation of thyroglobulin measurement for the surveillance of differentiated thyroid cancer. Thyroid peroxidase antibodies is usually measured by ultrasensitive immunoradiometric assays. Thyroglobulin antibody also can be measured with this method, although other techniques such as radioimmunoassay or enzyme-linked immunosorbent assay (ELISA) are also accepted. These two tests are often ordered together and are generally readily available in most clinical laboratories. Measurement of TR antibody is typically reserved for diagnostic confirmation of Graves' disease, as it is positive in over 90% of patients with this diagnosis. The TR antibody measurement is typically performed in one of two ways. One, a TSH receptor binding inhibitory immunoglobulin bioassay, which detects immunoglobulin inhibiting the binding of TSH to recombinant TSH receptor. A thyroid stimulating immunoglobulin TSI bioassay, which more specifically detects the stimulatory subtype of TR antibodies that activates the TSH receptor on the thyroid follicular cells. TSI measurement has been hypothesized to be more closely correlated with the severity of active Graves' disease. Both of these tests are currently more resource intensive and costly. As such, their additional utility beyond other diagnostic methods for Graves, namely history and physical examination, thyroid function tests, and measurement of other thyroid autoantibodies, neck ultrasound, and thyroid optic scan remains unclear. Most agree about their utility in specific situations such as diagnostic challenges in the patients with nodular goiter and hyperthyroidism, eye disease, and diagnosis and surveillance during pregnancy. Moving on to the thyroglobulin. Thyroglobulin is a large 660 kilodalton glycosylated protein that acts as a precursor protein for the active iodinated forms of thyroid hormone. Although the majority of thyroglobulin is stored in colloid within the thyroid follicles, a small amount of thyroglobulin escapes into the systemic circulation during the conversion process of T4 and T3 and is thus detectable in peripheral blood. Thyroglobulin can be particularly elevated in patients with differentiated thyroid cancer, although with low diagnostic utility for routine measurement or prior to total thyroidectomy. On the other hand, post-operative serum thyroglobulin measurement after total thyroidectomy for differentiated thyroid carcinoma remains among the most sensitive cancer biomarkers in existence today, with the caveat that its accuracy depends on the absence of thyroglobulin antibodies. Currently widely used immunoassay methods for thyroglobulin measurement include ELISA, enzyme multiplied immunoassay, fluorescence polarization immunoassay, and immunochemilumiноmetric assay. All of these immunoassay methods have made thyroglobulin measurement highly sensitive and specific, such that it is possible to detect thyroglobulin down to the 0.1 nanogram per milliliter level. For postoperative surveillance of differentiated thyroid cancer, the sensitivity of thyroglobulin measurement can be augmented further with TSH stimulation, either following withdrawal of thyroid hormone or after injection of the recombinant human TSH. A stimulated thyroglobulin of more than 1 to 2 nanogram per milliliter is considered higher risk for persistent or recurrent disease in the post-thyroidectomy setting. The accuracy of the serum thyroglobulin testing is highly dependent upon the absence of thyroglobulin antibodies, which must be obtained at the same time. Thyroglobulin antibodies is present in 10 to 15% of the general population and can limit the interpretability of postoperative thyroglobulin measurement. Even in those scenarios, thyroglobulin antibodies often can be used as a true surrogate biomarker since autoantibodies can disappear over time after the successful treatment of thyroid cancer. In addition, an increase in thyroglobulin antibodies levels can signify disease recurrence. Newer thyroglobulin assays that employ mass spectrometry offer reasonable detection of capability even in the presence of thyroglobulin antibodies, with sensitivities down to 0.5 nanogram per milliliter, approaching those of the immunoassay. Now lastly, calcitonin. It is a 32 amino acid protein secreted by the parafollicular C cells. Normally, serum calcitonin levels are highest in the infancy, decline rapidly in the early childhood, then remain relatively stable through adulthood, although absolute levels can fluctuate minute to minute. Calcitonin does not appear to play a significant role in calcium homeostasis, despite its known mechanism of action at the level of the bone, gut, and kidney. The serum calcitonin is the most sensitive biomarker for the detection and surveillance of medullary carcinoma of thyroid, which is a malignancy of parafollicular C cells. This test is performed in patients with or family members at risk of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. There is a controversy around the utility of measuring serum calcitonin as a routine screening test in the evaluation of a thyroid nodule. Calcitonin is currently measured using a variety of methods including radioimmunoassays, enzyme-linked immunosorbent assay, and immunochemilumiноmetric assay with differing sensitivities, specificities, and reference ranges.